I'm going to introduce our final speaker, Dr. Kelly Murray. Dr. Murray is a clinical associate professor of clinical pharmacy at Oklahoma State University Center for Health Sciences. She completed her pharmacy degree at the University of Oklahoma College of Pharmacy and is board certified in ambulatory care pharmacotherapy. Today, Dr. Murray will give a brief overview of polypharmacy and go straight into our panel discussion. So please join me in welcoming Dr. Kelly Murray. Thank you.
All right, I'm a little bit shorter than everybody else, so I'm going to do this. Hopefully that's okay. Thank you so much for that introduction. I also want to make sure that I thank the Osteopathic Founders Foundation and St. Francis for the opportunity to get to come here today. Thank you for inviting me. I really am truly honored. I'm so excited to get the opportunity to chat. Oh, slide advancer, this one. Okay, I'm so excited to get the opportunity to chat with this. As Dr. Beaman alluded to, I am just only this much of this presentation. The majority of what we're going to be doing is going to invite our panelists back up to the stage to talk about polypharmacy and what we can do about this. But as I was preparing for this, I was thinking about what polypharmacy means to me. And a quote came up in my mind from Mae West, who's a famous American actress. She's a comedian. She's a little tongue-in-cheek, if you know anything about Mae West, and she says, if a little is great and a lot is better, then way too much is just about right, which I think is pretty funny. And I think this applies to a few different areas in life, right? So when I'm thinking about this, desserts come up, so way too much, I'm all right with that. A day where it's all dessert day, I like that. Ice cream's pretty big in my house, so we kind of like that too. I also think vacation days are one of these times where way too much, I think, nobody would argue too much about that. So, big fan of that. And then puppies, right? I love a Basset Hound puppy, but way too many Basset Hound puppies, that's gotta be a good thing. But when does this not apply, right? There are a few different times in life. I know our speaker, Dr. Chang, would probably agree. He comes from Seattle, that sometimes rain is great. Oklahoma, we need rain for our crops, but every now and again, too much rain is not going to be good, and we get a little tired of it. In 2019, I don't know if you guys remember the flood, but I live on the Caney River, and we had a U-Haul parked out in front of our house, ready to throw things in it and move because the river kept creeping closer and closer. So something that came up whenever I was looking through this was the law of diminishing marginal utility, which basically says the more and more you get of something, the less the quality of that unit is. And so I think this can kind of apply in different areas. Candy is another one of those areas where I think the more and more and more you eat, the less it really means and the less you like it. My kids would probably disagree with this. But the time that I think about that really matters is whenever I drink way too many espressos in the day. That last espresso is the one that I regret, right? It's just probably not great. So we're not here to talk about all these things that I like and I don't like and maybe have had too many of. We're here to talk about polypharmacy. So this is one of those times where having too many may not be as great for our patients. So here's my contact information. I'd be happy to take emails if anyone has questions after this. You can reach me here. I do have financial disclosures. I have a relationship with McGraw-Hill in a couple different fashions, and those have been resolved prior to the start of this talk. So at the end of this chat, I'd like to be able to introduce you to concepts that were made by the Choosing Wisely campaign. So maybe that is a familiar term for some of you, but if not, we'll talk about these and what these mean as far as polypharmacy and mental health medications are concerned. We'll also talk about strategies to help with deprescribing medicines in primary care specifically. So, what is polypharmacy? Polypharmacy is a loosely defined term that really doesn't have a ton of data to support what that means. It may be different for each patient, but in general, that's going to be the regular use of 5 medications. And when I think about this, there are so many patients that come into the emergency department where I practice that have way more than 5 medications on their medicine list. I don't think it's that uncommon, actually. In particular, a lot of these medicines are going to be required based on the diagnoses that your patients have. So, regular and needed medications that are important, right? But sometimes these are going to start causing problems for your patients that may cause some increase in risk of adverse effects, which as we start stacking medications on top of each other, we do run the risk of having more of these. And those adverse effects are, in some literature sites that I reviewed, responsible for up to 15% of reasons for hospitalizations in our patients that are 65 years of age and older. So very consequential when it comes to adding medicines on. They also can increase the financial burden for your patient. So this is something that kind of adds in. It's not necessarily one of those clinical outcomes that we truly look at, but it is something to consider because if your patient is financially burdened, that next medicine that may be the one that's going to benefit them the most, they're not going to be able to afford, particularly in our patients that have restrictions with their insurances and can only get a certain number of punches per month, right? So what about mental health? Mental health patients with mental health diagnoses have particularly increased risk when it comes to polypharmacy. This is often a population that's overlooked, and we have these opportunities throughout their course of the diagnosis where we have more and more medications that are needed. Obviously, we've had a ton of providers, wonderful presentations today where we talk about augmenting therapies and adding therapies and switching therapies, which are all incredibly important and required for certain patients. But how that can happen is they can start stacking on top of each other where one may not be as beneficial as the next, and maybe we need to stop one. So what does that look like? So we may have that one psychotropic that we start the patient out on, and it kind of works. We've got about a 50% response rate, so we're going to add another medicine on to kind of help with that augmentation for a partial response. But then we need to add something else on to help escalate therapy. So now we have 3 medicines on board, but unfortunately, since those are kind of starting to stack on top of each other, we're going to now need some medications to help the adverse effects that come from those. I think about Dr. McClanahan's talk from this morning about how these antipsychotics carry a lot of metabolic syndrome risks, and this is not uncommon in Oklahoma. We've got these drugs that can cause weight gain, and they can cause diabetes, and they can cause increase in blood pressure, cholesterol, all of these types of things. And again, all of those things start stacking on top of each other. And it's not uncommon to require that many medications, but what can we do about it? A few of the risk factors that I looked into whenever I was evaluating the literature are patient and then healthcare system specific. So when it comes to the patient, I think of the age of the patient. So anyone older than 62 is at risk for polypharmacy. Anyone with a developmental delay or cognitive impairment. If they lack a primary care provider, so these probably wouldn't be your patients in your office, but the folks that haven't been connected with you yet. And those in particular with mental health conditions, again, keep coming up in any research that I did as one of those big risk factors for polypharmacy. Those with multiple chronic disease states like cardiovascular disease, coronary artery disease, diabetes, pain, all of those types of patients are going to be more at risk for polypharmacy. Those residing in a long-term care facility, one research report that I read showed that 91% of patients in long-term care facilities have at least 5 medications on their list. And then seeing multiple subspecialists. So the more specialists they have, that makes sense that the more medicines are going to get prescribed. Sometimes those are needed. What about the healthcare system specifically? So those that are maybe have facilities that lend themselves to less great record keeping. That might be one of those areas, a place where there may be poor transitions of care. So getting people from one doctor to the next or one care facility to the next may put them more at risk for polypharmacy. Prescribing to meet disease-specific quality measures. And then one, as a pharmacist, that kind of hits close to my heart is the use of automated refill systems. So does anybody else hate these as much as I do? Yes, okay, so same. This is one of those times where I think that those automated refill systems, that you're gonna start mailing your patients the medicines that you discontinued. And then the patient's gonna be like, oh, well, I got it, so maybe my doc still wants me to take that. And then it's continually added onto that list. And so it's one of those really big frustrating points for me. Wrong button, yep. All right, so let's talk about those negative consequences when it comes to the patients. So when you're thinking about polypharmacy and what that impacts the patient as, it's gonna be a decrease in quality of life. We may have mobility issues because of these different medicines that are stacked on top of each other. You might see an increase in mortality, obviously an increase in use of the healthcare system that may be as a result of adverse drug events that come about from multiple meds, cost to patients, and then an increased risk of adverse drug events, of disability, of inappropriate medication use, long-term care placement, as well as non-adherence. The more medicines you have, the less likely they are going to take them as prescribed. But what about the risks to you, like the risks to the doc, the risks to those of you all that are in the room and the healthcare system in general? The increase in medication errors are going to increase the patient load that you see in the hospital system. You might have a decrease in physician productivity because you're having to deal with all of these refills, and you have a lot of questions to ask the patients when they come in. So just many different things to think about. So what can we do about this? Obviously, we're going to bring our panelists up. They have great advice for you. But when I think of this, I think of more of like a reactive strategy and a proactive strategy. So when you're thinking about the proactive strategy, this is obviously going to be the easiest way to kind of prevent these polypharmacy situations from happening. And we'll talk about that first. So when you're looking at preventing polypharmacy, you want to collaborate with the team around you. So what other docs, what other prescribers are on this patient's care team, and how can we best coordinate the care with them? Also evaluate for non-adherence. So oftentimes I see patients who get prescribed a medicine, they may not be taking the medicine as prescribed, but if it's not working, you're gonna add another medicine on instead of optimizing, or maybe trying to figure out why it is that they didn't take the medicine first. We'll talk about best practices and how to best educate. Obviously, you guys are here, you guys are lifelong learners in the medical field, and so this is something that can be beneficial and help. And then those systems-based approaches to minimize polypharmacy, which can also be beneficial, like thinking about the refill durations. How often do you want to see the patient back in your clinic? That could then determine what that refill is that you put on the prescription, and then recommend not doing those automated refills if the patient is okay with that, I suppose. The other thing that I read was considering medicines that you add onto their chart as a trial and not a permanent fixture on their medicine list. And I thought that was a pretty nice way to say, we're going to try this, we're going to see if it works, and if it doesn't work, then we're going to change to something else. So improving treatment adherence is something that I think is going to be great. Again, we can optimize the medicines that are on the list to start out with by making sure we're building that therapeutic alliance with rapport with the patients. Detailing the treatments that you're giving them as well as the adverse effects to expect and those that will go away with time. Communicating with them on a regular basis and including them in those decision-making processes is always going to be something that will help. And then using that shared decision-making as well. So what do we do to manage polypharmacy? So if we get the patient, we inherit that legacy patient into the clinic that has the huge medication list, what are some of the ways that you can start deprescribing? The first thing is to reconcile those medicine lists at every single visit, if possible. You can include your staff on helping how to do this. Nurses can do this. Obviously, pharmacy personnel can as well. And I like to try to focus in on some specific opportunities to where you might get the most bang from your buck. And that's going to be the Beers criteria for your elderly patients, as well as evaluating for drug interactions, which everybody kind of has their favorite drug interaction program. I like LexiComplete. Epocrates is also a great one. So for the Beers criteria, you're going to think about which medicines may be potentially inappropriate, as well as inappropriate based on certain disease states. You can also look at which medicine should be used with caution, which may have inappropriate drug-drug interactions with those systems that we talked about, and which need to be adjusted based on renal function. And you can also look for drug interactions based on classes of medicine. So in the mental health world, I think about how a lot of different medicines have similar activity at receptors, which may be why we're using those in the first place. But you look at all of the medicines for serotonin. Are we adding any increase in risk of serotonin syndrome by stacking medicines on top of each other that we may just be able to optimize one? I also think about the added medicines that have like sneaky serotonin effects, like cyclobenzaprine or linezolid for skin and soft tissue infections that can cause the increase in risk of serotonin syndrome also. I think about anticholinergics. We have a ton of medicines that act at these receptors, as well as any medicine that acts at the CNS level that causes sedation. Those are going to put your patient at risk as well. Other things that you can do would be initiate within your clinics, within your sites, quality improvement projects that can target certain campaigns, like the Choosing Wisely campaign. Let's go through what some of those recommendations are for psychiatry specifically. They recommend not prescribing antipsychotic medications to patient for any indication without appropriate initial evaluation and ongoing monitoring. They recommend not routinely prescribing 2 or more antipsychotics concurrently. Not routinely using antipsychotics as a first choice to treat behavioral and psychological symptoms of dementia. Not routinely prescribing antipsychotic meds for first-line interventions for insomnia in adults. And not routinely prescribing antipsychotic meds to treat emotional and behavioral symptoms in childhood without approved or evidence-based indications. I also looked in our pharmacy world, we also have Choosing Wisely campaign recommendations that look into making sure that we don't prescribe medications during care transitions when there are higher risks for errors that may occur, including duplication of medicines, drug interactions, and adverse events. Not initiating medications to treat symptoms without determining if we can adjust the medicine that may be causing that symptom. And not prescribing or indefinitely continuing medications for patients on 5 or more meds without doing a comprehensive medication review. So lastly, a strategy would be to deprescribe when appropriate, which again, we'll get a lot of good advice on this from our panelists. This is ultimately a systematic approach to identify and discontinue medications in instances in which our existing potential harms outweigh those benefits and why we prescribed it in the first place. So our guidelines talk about how and when to initiate therapies, but our guidelines don't do a great job of talking about when to de-initiate or de-prescribe those therapies. So one reference that I did find gave a pretty good strategy on how to de-prescribe. So if you take a patient's medicine list and you review all of the current medicines, you're going to ask yourself 6 questions about each of those. And those are going to be, is this medicine potentially inappropriate? Does it lack an indication? Is it failing to provide any additional benefit? Does it lack efficacy? Is it causing adverse effects, or is it too complex in its regimen? You're then going to take that information, you're going to chat with the patient about it and kind of get their feelings on it. Again, that shared decision making is important, and re-review regularly. So with that, I would love to welcome back our panelists. Obviously, I can give you a lot of information, but these guys are the ones that are doing this in practice, and they can really help give us some advice. You guys have been so awesome about asking questions. If you guys want to come up to the stage, that'd be awesome. You all have been wonderful in asking questions. I want you all to ask questions throughout this, but I do have certain questions that are plugged in just in case we need to get the ball rolling. So, as everyone is getting set, does anyone have any questions to start out with? Yes, sir. Do I need to?
We treat, say, a patient with substance use disorder with. We treat a patient with, say, a substance use disorder with alcohol. We don't necessarily give, we try to, maybe use Librium or something to help them gradually, lower their dependence. My question really is about, with opioids, now we have medical opioids to help people that have substance use disorder. Why do we not have medical alcohol? Why do we not have medical stimulants? I guess my question is kind of toward the whole idea of continuing people almost indefinitely on opioids, when would it be better to, do a gradual taper and eventually, remove them from that?
Yeah, sure. I think that's a great question. I think you're referring to methadone and buprenorphine, which are opioid-based products that are approved and recommended for the treatment of opioid use disorder. And so there's a lot to unpack there, and I'll see if I can do my best. We have done extensive studies in tapering individuals who are on methadone and buprenorphine. Even up to 5 years of treatment, they will still fall back onto the opioids. So what I like to say is that my number one goal in using methadone, or I don't use that, I use buprenorphine, is to keep people alive, because if you're alive, I can help you. If not, I have zero chance of helping you. They do have to take a pill for the rest of their life, but that's the same for some people with cancer, some people with diabetes, high blood pressure. You take a pill and you function. And so these individuals are taking a pill, but they're functioning, and they're not getting arrested, they're not dying, they're not going to prison, losing their jobs, all of that stuff. We have looked at, generally what you're describing is the concept of harm reduction. And we have looked at harm reduction techniques with stimulants. And I was just talking to another participant earlier about replacement therapy for replacement therapy. I don't feel like my mic's on. It is. We're talking about replacement therapy for methamphetamine addiction with Adderall, right? It's a very similar concept with opioids and methadone or buprenorphine. We've studied that. And it turns out that if you give a patient addicted to methamphetamine Adderall, they just use that on top of their methamphetamine, and you don't get any kind of benefit or results. So with alcohol, I think one of the big differences with alcohol and other substances is similar to methamphetamine. Methamphetamine, when you use it, it destroys your brain, and you get brain damage over time. Alcohol is toxic to the body. And so I don't know that we could recommend someone take alcohol for the rest of their life if they were addicted to it, because that's a toxin. So I think it's all risk-benefit.
I think, to clarify, I'm saying that, you know, our recommendation to the patient is don't use alcohol, right? And I'm kind of confused as to, you know, how many patients I see. There was someone that came to our property to cut a tree down. They work in tree cutting business, and yet they take a pretty strong amount of opioids. And they found out I was a physician, and they started asking me, and I said, well, I really don't work with a lot of controlled substances.
Yeah.
I'll try to avoid it. And they start talking about, well, now I have to go to Tulsa to have this. My question is, the goal with patients with alcohol substance use is to stop taking alcohol.
It's not necessarily that. I do concede your point, and we would never recommend someone to start a substance. Obviously, they're coming to us normally on the substance. A lot of times in addiction treatment, our goal may not be complete abstinence. It may be reduction in use and reduction in dysfunction from the use of the substance. And so that would be our recommendation. But also in the addiction world, we can't lump all addictions together because they do have intricate differences. Opioids are very different from alcohol. If someone comes to me addicted to alcohol, I would not say, well, don't drink alcohol. I would offer them one of the 3 medications approved for the treatment of alcohol, and then also substance, like psychosocial treatment for addiction, which is very beneficial. Yeah. Good question, though. Good question.
Sorry, my last comment on it, but not every patient needs buprenorphine.
No, every patient is different. Not everybody needs us. I highly, as an addiction doctor, I feel obligated to say I highly recommend not doing anything cold turkey or force rapid tapers for opioid use, but not everyone's going to benefit from buprenorphine. Not everyone's going to benefit from naltrexone or methadone. It really does need to be an individualized approach. Yeah. Other questions?
I have a large number of Suboxone patients, over 100. Several of them came to me on Adderall. Do you do both?
No. I mean, I think you can all imagine what my answer would be. Absolutely not. The guidelines will tell you that you should treat an individual with opioid use disorder and ADHD the way you would treat someone with ADHD without opioid use disorder. what I would say is that is a very, very tricky situation. I subscribe to the philosophy that if you have been addicted to a substance, then you are highly, highly likely to get addicted to another substance. There is nothing magic about the reward center of the brain that goes away if you have ADHD. So you can have ADHD and Adderall addiction at the exact same time. Also, individuals that have been in the throes of opioid addiction have friends, family, contacts that are in that dark, shady world of drug dealing that in my mind happens outside of a Quick Trip, but Quick Trips are pretty nice, so I don't know why I think that. So I don't want to increase the risk of diversion by contributing to that. Also, you really do have to have a very good evaluation of the ADHD diagnosis and how much of that was attributed to opioid use, how much of that is attributed to being in recovery, what stage of recovery are they in. Buprenorphine itself does not have cognitive deficits. So it's not like an opioid where the more opioid you use, you're going to start to lose your ability to think clearly or whatnot. Buprenorphine has a ceiling effect and doesn't cause that. But I would highly, highly recommend not treating somebody with buprenorphine and Adderall at the same time.
So how do you wean them off of the Adderall at that point? Just slowly?
Probably not that slowly. I think if you trust that there's no diversion going on, maybe over a month. Whereas a benzo taper I may do over 2 years. But Adderall I would probably do within a month. Yeah. Remember that individuals who have an addiction are used to feeling uncomfortable and taking a pill. And we don't want to reinforce that. We want them to get used to what their mind is like and what their reality is like.
Most Suboxone ones I have that are just on Suboxone tell me when they got off of the opiates, they no longer had a need for a pill.
Yeah. Yeah.
What other questions? Yes, ma'am.
This question is actually for you.
Oh, great.
So I had a legacy patient that was on 35 different pills, okay? Of the 35, maybe 15 were prescription pills for different reasons. The others were minerals, supplements, and other types of medicines. I have gradually convinced her to come down to about, we're at 16 now, right? How do I get her off of all this stuff? So I've worked on the things that are reasonable, like, consolidated blood pressure medicines, looked at things, got rid of things that shouldn't be there. But my problem is all the supplements and minerals.
Yep. I think you ask a really great question. And this is one that, you'll see occasionally when it comes up. You'll see that medicine list or, in the ER, you've got the patient that brings the tote in with them and is like, all right, I'm ready. And that's my nightmare. So when it comes to trying to talk about these, I think the best thing that you can do is to try to figure out what the reason is behind the medicines. What is this medicine doing for you? What is the reason that we're taking this one? How do you take it? How many pills? How many times a day? What does it cost? Because that's got to be prohibitive in some ways. Which one is the one that gives you the least amount of benefit and costs you the most? So you can kind of start there as well. I think the other thing is to kind of give them the information. So whenever you're using your motivational interviewing strategies, talk to them about, what is it that we get the benefit from here? May I provide you some information that I've learned about some of these supplements? And if they agree to that and they say, yeah, let's talk about it, then you can start talking about, well, actually this medicine isn't really well studied for the condition that you're taking it for. What we actually saw was this medicine was better and you're on this indicated medicine. And so I don't think you're going to notice much different here. One other thing that I kind of think about in this realm is like the added harms, right? So like you look at the efficacy and then you look at the safety piece of it. So many of those minerals in the supplements that we can get over the counter are cations, and those cations are gonna bind and cause other medicines to be ineffective, right? Yeah, like all things you've probably already thought about and you're like, okay, what do I do now? So I think it's kind of working your way. I think you're doing the right thing and you've built that therapeutic alliance with this patient. It sounds like you've got really great rapport. They keep coming back to see you, which is a great sign, even though you're taking things away and you're like, you shouldn't do this. Keep working on it. Like keep working, keep chipping away, but also talk about like, hey, I'm really concerned about this. We're gonna prescribe you doxycycline for this skin condition. That's going to be interacted and you're not going to get well treated because of all of these other medicines that you've got on board. So I really need you to stop. While you're stopping, look to see how those conditions that you're taking these for are affected. And then they can kind of start tracking on whether or not they actually see a benefit when it gets taken away. So, other thoughts? You guys probably see this as well.
I think you hit the nail on the head.
Oh, sweet.
Yeah, I
Awesome.
like your comment about, let's talk about taking away this one medication that you're taking for whatever this ailment is. And is it really different now?
Right.
That you're off of it?
Right.
You know, and how well do you feel if you're taking, you said 35,
Started there.
something like that? Per Google.
Hey, that's remarkable, honestly. Like, that's hard to do. Good question. Other questions from our audience? Yes, ma'am. Okay, love it.
So in reference to like Suboxone and things like that that you can be addicted to, which every one of my opinion you can be addicted to, but you got to do a lot of studies and research. So have you done studies in reference to the placebo effect, like with Suboxone and things like that? Because I know patients and clients and things who have been like, oh, I've been on this for 15 years. In my mind, I'm going, well, first you're addicted to that, and second, is it your mind telling you that you need this every single day, or where does it trend down?
Yeah, so specifically with Suboxone, we've done a lot of studies. I'm not sure of placebo studies. I know that they've been done. I just can't think of them off the top of my head. But we measure a lot of things, including three big things. One is craving scores. So we ask people their cravings. And individuals on Suboxone versus a placebo have or individuals not on a medication, not necessarily placebo, but if they're on Suboxone versus no medication, they have much decreased cravings. And then we look at urine drug screens. And individuals who take Suboxone, 80% of them will have consecutive negative urine drug screens over a 13-month period. Compared to about 6% of people who are not on Suboxone. And then the last one is the compliance with their appointments. So individuals who are on Suboxone keep coming to their addiction doctor, to their primary care doctor for treatment much, much more often than people who are not on any kind of medication for it. So because of that, it's those reasons that both the CDC and, well, not both, but the CDC and all major medical organizations recommend medications for opioid use disorder. There's three. Methadone that can only be given in a methadone clinic. Now, you guys can prescribe methadone for pain. You cannot prescribe methadone for opioid addiction. That's against the law, so don't do that. So methadone, buprenorphine, which now you can all prescribe without a waiver, no limits or anything like that. You can prescribe that out of your clinic. And then extended release naltrexone, Vivitrol, which is not a controlled substance. It has no euphoria, has no addiction, anything like that.
Great. So I'm going to add a question just while you guys are formulating thoughts, and if you think of anything else, like let's keep going with our audience questions. But I did plan for the chance to ask a few myself, and I'd love to know from our panelists that are on the stage, in your practice and based on your presentations today, what polypharmacy examples do you see most often?
So my practice location is a little different. I work at the Oklahoma Forensic Center, which is our only state hospital here in Oklahoma. So all of my patients have some sort of legal element to their situations as well. With that being said, a lot of patients are treatment refractory. A lot of patients have significant histories of violence, but I started there last July, and I will tell you what, I've never seen so many antipsychotics given to one human at one time. It blew my mind. And so I'm going in and, decreasing everything, and the nurses are freaking out, and they think there's going to be like this awful, it's fine, everyone's fine. But I think that we run into that a lot, where this person's maxed out on risperidone. They're still psychotic, but we don't want them to get more psychotic, so we're going to leave it. And then we're going to start something else. And they're still psychotic, so we're going to add this other thing. And they won't do labs, so we're not thinking about Clozaril maybe. So I think in that case, really looking at their baseline and their pre-medication function, are they 5% better? Okay, maybe then that's not worth the risks that this antipsychotic or whatever it is adding, right? We really need to see a significant improvement on that medication in order to leave it there and not switch it out with something else.
Yeah, sure. So when I think of polypharmacy, I see most of the problem with that on the consultation liaison service in the hospital, right? We'll often run into folks who are delirious, and you start looking at their medication list, and you end up maybe on 20 different things, right? And we start thinking of like drug-drug interactions. And in my experience, we think of pharmacokinetic interactions, drug inhibition, induction, that kind of thing. And in my experience, I have not seen an awful lot of that make a whole lot of difference pharmacokinetically, with the exception of probably lithium toxicity and things like anti-inflammatories. That's almost guaranteed problem, right? But we often, very, very often, will see pharmacodynamic interactions, right? There's a patient and you start looking at Beer's criteria, et cetera, and they're on, 4 different anticholinergic medicines, and they're on 3 different medications that, block alpha-1, and they're dizzy, right? So we see an awful lot of that. And sometimes our first approach to getting a patient to feeling better is start to kind of debride this list, right? So start taking things away, and they just feel better before, just because, based on things that we take away rather than what we're adding.
So as a sleep doc, you can imagine people may be on 4 or 5 different sleep aids. And what they tend to do is they alternate what day of the week what they'll take, right? So Monday night I'll take melatonin, the second night I'll take the Ambien, the third night, Wednesday night, I'll take trazodone, because if they take it consecutively, the medication is less effective, which is why cognitive behavioral therapy is much more long-term. Also, people use marijuana quite frequently up in Seattle. I think it's legal here in Oklahoma as well, and that's been a big problem. Interestingly, my folks in their 60s and 70s are using marijuana a lot. I think it throws them back to the time when they were younger, maybe. And so that's been a challenge, educating my patients and those who are using marijuana.
Thank you. Questions from the audience? Yes, sir.
I have a problem with patients who come back from the hospital with medications changed from what we knew about, but yet we don't have information because all we get from the hospital is just a discharge which the patient brings with them and says virtually nothing. And I know we're supposed to be getting it on our computers and all, but boy, it's iffy at times, and that to me
Very frustrating.
throws us into a bind because we don't know what they got.
Right.
I don't have a good answer. Sorry. I hope my health works.
Yeah, I would say my health also, though I would just point out, I think what you're acknowledging is that is one, and I think Dr. Murray would agree, that's a high-risk scenario for a bad outcome. You don't know that they were given linezolid, and you start them on Flexeril, and now all of a sudden you've got a serotonin syndrome. From a legal standpoint, like a malpractice liability, I do think you're obligated to try to get the records, but that can be an absolute nightmare. You're going to talk to the medical records department where someone's going to throw out some weird interpretation of HIPAA, and you're like, you sent them to me. Like, you should have, and I get it, but you should do that, and hopefully by the time they see you, they have it, or by the time they follow up, you have the records, and you can sort that out.
But our problem is when I'm in Rural, I'm in Bristol, and when they get there, they don't know, and so we get them to sign a release of medical records because we can't call and get them.
Yeah.
Non-hospital in Tulsa will release them unless sometimes I get online and my computer's got it. And but I'm not trying to throw stones, it's just life.
Yeah.
I'm going to throw out a plug for the medication reconciliation piece, which is a beast. Like whenever you're looking at a patient that has all those medicines and you're trying to write all of them down at one period of time, that's going to take up like beyond the amount of time that you had scheduled for that visit, right? So trying to figure out how best to like allocate that out to a different person in the office to like get that done before they come to see you. That may be pie in the sky and like a super hopeful, like who has that manpower these days, but like that might be something to try to start working in, or at least if they have that discharge summary from the hospital, fingers crossed that's documented on the discharge summary as to what was changed, or just like bring in the bottles. Oh, I'm sorry. It's awful. It's so hard. Yes, sir.
So on depressed patients that are on 2 antidepressants, so we're talking about polypharmacy. Do they need to be stable for 6 months or 1 year before you taper one? And do you just taper one at a time? Do you ever think about the receptors that you're having an effect on? And does that make your choice on what to taper?
Yeah, generally you want to continue a patient on the medicines that you added if it's giving benefit, right? You know, if someone's taking something like Zoloft and we've optimized that dose, that's a good point. We want to make sure that initially we've optimized the dose of the very first medication, that we've hit some sort of a plateau with it before we think about adding something else on. But generally, if I'm going to augment with an antidepressant, I'm going to continue them on that, because there's a good chance that the patient might relapse without it because the initial medication was not working well. Now, if we run into bad side effects, say, we think about antipsychotics and metabolic syndrome, we might try a trial off of that, but we do so very cautiously.
I need to run faster or wear different shoes. Oh, here we go. Sorry.
Oh, you're great. Thank you. My question is about marijuana. I'm not a proponent. I'll just say I have like a huge sheet that I give patients about the known risks and the theoretical risks and et cetera. But I was talking to a neuropsychologist who does a lot of my testing, and I asked him how an ADD, like a new ADHD diagnosis, could be valid in a patient who uses marijuana. And he told me that supposedly it's been long agreed upon by people in the neuropsychiatric field that cannabis can be a useful therapy for ADHD. And so, like, based on its widespread use and lack of like solid research on it and its quasi-legal status, I struggle now to take a hard line against it. So especially in patients who are just using like a tiny bit of an edible or something to help with sleep, should I really deny them a stimulant for like a seemingly legitimate ADD diagnosis? Just wondering if you can speak to that.
Well, I think you have to take the stance that you want to take, and definitely, as I've discovered, the way people practice medicine is not the way I practice medicine, and people are probably happier because of that, so I can understand that. I'm not aware of any such agreement, and I want to know this big group that got together and decided that. Maybe I was out sick that day. That is just nonsense. Now, your question about like taking a hardline stance, I think that's valid, but to say that we've agreed that it's a treatment or no, I think every professional organization, every psychiatrist, every psychologist, neuropsychologist would agree that marijuana is detrimental to focus, attention, and concentration, and would recommend not taking it if you have problems. And here's what I was telling Dr. Chang earlier about how I treat sleep, is we have all this sleep hygiene, and how many of us follow all the rules of sleep hygiene, right? I've got a TV in my bedroom, and my phone right there on the nightstand. But what I tell my patients is you don't have to do all that until you have trouble sleeping. Once you have trouble sleeping, then sleep hygiene becomes really, really important. And so you can use marijuana, okay, until you have trouble focusing. And if you have trouble focusing, don't come to me and say that you need an addictive pill to overcome that when you're using the marijuana. That would be different maybe if someone is diagnosed with it in childhood. Specifically taking an edible for sleep is kind of concerning for me because edibles have very high THC content. The studies have shown that that the efficacy of marijuana for sleep is highly dependent on the THC to CBD ratio. CBD very effective for sleep, THC actually not effective for sleep. And so they may actually be making that worse. Now they're getting a stimulant. Maybe they couldn't sleep because they were getting a stimulant. So there's a lot of intricacies with there. If it's your patient, you know the patient, and based on your practice of medicine, you feel okay with it, you're within the law. I don't know that anyone could fault you for that by using professional judgment, but I would tell whoever this neuropsychologist is that I don't think that's true. I don't know who the group is that agreed on that, but it wasn't.
Yeah, I would echo the same thing. There have been pretty consistent findings with problems with memory, executive function, and attention too with cannabis use. And this is outside, by the way, of even intoxication. You can have sobriety from cannabis for several weeks, if I'm recalling like 6 weeks or something like that, where you can still have some deficit. So in terms of it improving cognitive function, and with Dr. Beaman, I don't know where they're getting that. And I think it's an important thing, too, when we're thinking about neuropsychological referral with patients who are using cannabis regularly, saying, I've got ADHD, let me go get tested for this, and they're using cannabis daily, and then they go get neuropsychological testing and they do poorly. That's going to be biased, right? You're going to end up with a false positive on that test, right?
I probably don't need that either, but my question's for Dr. Chang about, since we're talking about deprescribing, how often do you have to deal with deprescribing sleep aids in your practice, like Ambien or other pharmacological medication?
That's a great question. I'm privileged to be a sleep doctor and not in the trenches like you guys are in primary care. So by the time someone's referred to me, they've gone through the litany of sleep aids, whether it's over-the-counter or prescribed. So I tell them, you've already gone down that road before. Let me offer you something else. Usually the primary care doctor who has referred the patient has primed the patient to say, this doctor is not prescribing you anything. So I would probably say my whole time doing sleep medicine for the last 16 years, I probably have a handful of times prescribed the sleep aid. That includes a sleep study. So I tried to prime the patients ahead of time what to expect about their sleep study, even though sleep aids do not affect EEG, okay? But from my perspective, I'm putting a sleep aid, why? Let's do the sleep study without the sleep aid. So I don't really prescribe, but I'm in a different realm than you guys, right? Like I said during my talk, out the door, you're running behind, and they go, I have a sleep problem. You're not going to talk about what I shared with you this morning. But me personally, I don't prescribe just because I know it works, but it's defined and there's side effects. Yeah.
Okay, I'm going to add another question to the list. How do you balance the risks and benefits of multiple psychotropics?
Really, like all of these answers are going to be, it's very patient dependent. My patients specifically at the hospital, their risk is very high of not being treated to an extent that sometimes they do need multiple psychotropics. So I think it's looking at the history. Is this person on a psychotropic? Are we adjuncting an antidepressant for, is there some Abilify on there, but then they're not sleeping, so we're going to add a little Seroquel. That's a different case than a person who is treatment refractory with schizophrenia and requires maybe a typical and an atypical, as much as we hate it. They don't get better until that happens. So I think it's very, very, very case dependent. What are you treating? And are there other options that don't multiply these risks over and over by adding multiple of the same type of medication for different indications?
I would agree with that, and I would say as a general rule, sometimes we do use multiple antipsychotics in the same patient. In my entire career, I think, and I specialize in severe mental illness, I've done it like 10 times in very, very complicated patients. As a general rule, it's one or the other. And you may see a patient of mine on 2, but I'm usually tapering one down and bringing the other one up. So antipsychotics, I highly avoid doing more than one at a time. Antidepressants, there's certain ones that play well with others. And as a general rule, you shouldn't have a patient on 2 SSRIs or an SSRI and an SNRI or 2 SNRIs. Remember that TCAs are not named on the receptor they work on like SSRIs are. They're named by their structure. So TCAs are, depending on the one you're talking about, are very serotonergic and can cause problems, or they're very norepinergic. And you just got to know which one that you're dealing with and what it is. So as a general rule, I avoid multiple medications in the same class. I think that's just a good rule of thumb for psychiatry.
Yeah, I don't think I have an awful lot to add. We just want to think about risk benefit. There's sometimes there's side effects that, sometimes we have to live with just because the medicines give them such benefit. If you look at multiple antipsychotics, et cetera, maybe metabolic syndrome and that kind of thing. But if it's keeping them out of the hospital, maybe it's worth it. You just have to meet the patient where they are. And I echo what Dr. Beaman said. You need to be cautious when we think about combining medications of being familiar with our receptors, right? We're not giving more than, you don't want to give 2 SSRIs, right? That doesn't make an awful lot of sense, right? Yeah.
I'll pass on this question.
I love it. Next question. Yes, ma'am. Coming to you.
For Dr. Chang, I'm like you. I don't give sleep aids for the most part, but I get patients that come to me who have been on them for a lot of years, and I think you probably do too. What's your approach for deprescribing those with those patients? Thank you.
A really outstanding question, just because sometimes there's legacy patients that you inherit, right? And it's a challenge because they rely on these medications. It works, but yet, like someone alluded to earlier, could there be also placebo effect to these medications? Is there tolerance, but because they're popping the pill, I can sleep, but without the pill, I'm doomed for the evening. And during my talk, I did talk about incorporating cognitive behavioral therapy as a bridge to weaning them off. The challenge is selling the cognitive behavioral therapy to these patients. Why do I want to do CBTI if I have the prescription coming my way? And so that's the hard part. I think I was talking to one of our colleagues here at one of the breaks about how do you sell cognitive behavioral therapy. No one wants to do it, to be honest with you, because one of the challenges, you will feel worse before you feel better. I didn't say that in my talk, but I let the patients know, right? You're changing a lot of behaviors as it relates to your sleep. So you have to have a very motivated patient, and finding someone that understands the cognitive behavioral therapy for insomnia, because it's a defined period of time. It's not like dealing with agoraphobia, right? Going to a therapist. CBTI is like 3 to 6 visits total. And it's very gratifying for the person practicing cognitive behavioral therapy because you see the benefit of that individual over time. And so for me, I would embrace the behavioral therapy, have it part of their routine. Once their insomnia is better managed through that, then talk to them about weaning gradually, rather than going cold turkey. Yeah.
Yes.
Okay.
Kind of along that question, I tend to get a lot of people coming to me that have been prescribed Adderall before, and we talked about prescribing. What are our options as far as in saying, I don't plan to
And are you specifically asking about Adderall? Yeah, so I think it gets tricky, and this is actually a question that I have for the medical board, is there an obligation if you're within a health system that, you work for Acme Health Group, your partner was a huge friendly prescriber, very loose with the medications, and then he got arrested or is no longer practicing. And so you inherited all of his patients, his diabetes, his blood pressure, but also his controlled substances. In that case, you may have some obligation to continue medication to avoid a harmful outcome. You never have an obligation to use medications that you feel are inappropriate. But the tricky one is benzodiazepines. So the call I got last week was a patient on 10 milligrams of Xanax a day for 15 years. And it's like, after the first 9 milligrams, what did you think you were going to get out of the 10th? And with the physician I talked to, I was like, this guy's going to have a seizure, right? And I don't think you're under any obligation to see him, new patient, but he's going to have a seizure, and there may be an opportunity here for you to help that. So I think within the health group, you have liability with benzos, and you do, probably the best thing would be for you to take them for a taper. When it comes to patients from outside your system, new patient, you have zero obligation, right? It's the exact same thing that, well, Dr. Beaman thinks that if you look at the sun and if you're looking just off an angle, you have cancer, and he gives you chemotherapy. So I'm just here for my chemotherapy. You're like, that's nonsense. I'm not going to do that. You would never do that, right? It's the same exact thing. And you can say, I don't treat ADHD. You're under no legal obligation to treat ADHD. So you can just tell them that. One of my mentors in medical school said he did not take any new patients that were on opioids. Now, his patients that he'd taken care of for a long time, if they needed opioids, he would treat that. But he would not take anyone coming to him on opioids. And I mean, he's perfectly within his rights to do that. You need to be conscious of your health system, of your insurance providers, on what their requirements are for you seeing patients. Outside of that, you're not under any obligation. Physicians are allowed to choose who they take on as patients and who they don't. Yeah. Dr. Land.
So if you have a patient come in and they're new, you look at their bed list, and you know right off the bat you're not going to do it, do you tell them before they come back? Do you bring them to your room and say, look, I see your bed list, I just want you to know I'm not going to do this, or how do you handle that?
Yeah, I highly, highly recommend you tell them before they come back. It only goes south from there. That does not end pleasant for anyone. We have now added it to our treatment agreement that we do not do long-term benzodiazepine therapy, that they have to sign before they come into the room. And we have signs posted in our clinic telling them as such. And then it's only happened once, but the patient was really mad and was like, why did I sit here and answer all these questions if you're not going to give me what I know works for me? And I said, is this your signature right here? You said, and she just says, I didn't read that one. Not my fault. So yeah, I highly, because you don't want them to pay money, and it's I'm not saying anything about you, I'm just saying it's not something we do. If you want to visit, we're happy to do it, but just know that that's not going to happen today. Yeah.
Right, wonderful. Thank you all so much for your questions. I did not need to plan as many that I wrote. You guys had great ones. So I have a few key takeaways for the presentation today. I would love our panels to add in any other key takeaways that they have. The first one for me is older adults and patients with mental health diagnoses are particularly at risk for polypharmacy and the consequences thereof. So those medication reconciliation strategies may be helpful to kind of help minimize some of those risks, and developing a plan to deprescribe with you and your patient's goals in mind is important. One thing that I will put another plug in, Dr. Gill actually already mentioned it, is we do have a mental health project ECHO at OSU. If you search echo.okstate oklahomastate.edu. I am lucky enough to get to be the pharmacist on the adult mental health as well as the pediatric emotional and behavioral health echoes and the peds obesity echo. So it's kind of like all the worlds rolled into one that I love. So please feel free to join us. That's a place where we can take your patient cases. They're all de-identified as a teleeducation opportunity. And we'd love to see you on those dates. Our panelists, any other feedback or thoughts to take away today? Okay, wonderful. Well, I appreciate your time. Thank you for the opportunity for the chance to speak today.